Coming to you from Beaumont, this is your house call.
I'm thinking about a patient whose story is becoming all too common in our world today. She's a middle-aged woman, relatively healthy overall, not a lot of medical problems. One day she's working around the house or she's working in the garden and she injures her back from overuse. Initially, she manages the pain with over-the-counter pain medications, anti-inflammatories, but the pain doesn't improve, so she goes to her primary care doctor. She's prescribed a regimen of physical therapy, and she's eventually told that she may need back surgery to help fix a bulging disc in her spine. She's also given opioid pain medications to help take the edge off. Fast forward several months down the road, now she's on disability because the pain is so severe that she can't work. She's depressed because she can't do the things she used to do. And she's frankly become dependent on opioids to get her through the day. This story is tragic and familiar to millions across the country. Today's conversation is all about the opioid epidemic. We'll discuss the scope and the origins of the opioid crisis, and we'll get at ways to mitigate it at the level of the patient, as well as ways to manage this problem on a more macro level. Hello and welcome to the Beaumont HouseCall podcast. I'm Dr. Nick Gilpin. Today it's all about opioids, chronic pain, and pain management, and our guest for this conversation is Dr. Bruce Hillenberg. Dr. Hillenberg is a chief psychologist in pain management at Beaumont. He's the chief of pain management services for the Beaumont system, which is a group established to tackle opioid and chronic pain management related issues across Beaumont's entire healthcare system. In our chat today, we'll be focused on a few key areas. We'll frame up the conversation briefly with some historical perspectives on pain management as it relates to the opioid epidemic. In other words, how did we get here? We'll spend a little time talking about how our current healthcare laws may be helping or possibly hurting our progress on this front. And then we'll get into strategies for coping and managing chronic pain, both pharmacological and non-pharmacological in nature. And with that, I will welcome our guest, Dr. Bruce Hillenberg. Thank you for coming on the podcast.
Thank you. I'm glad to be here today.
Appreciate having you in the studio. Bruce, can you tell us a little bit about yourself and how did you end up becoming Beaumont's pain management guru?
Okay. Well, I've been a psychologist almost 40 years. And in my 20s and 30s, I had a couple of back surgeries because I suffered from back pain in my late teens and into my early 20s. And I got some partial success from those surgeries, but not complete success. Did try some opioid medication at that time, codeine, but over time began to realize that this was probably something I would be living with, and I had to figure out how to manage it and try to have the best life possible. So I really began to study that. Read as much as I could about how to cope with pain, through my own effort rather than medical treatment. And in my discoveries, I became very interested in how other people did that. I then went back to school, became a clinical health psychologist, and right at the time I went to graduate school was really the beginning of pain psychology, psychologists working with medical team members to address pain. And I really developed a big interest in the whole pain management area.
Well, I know for a fact that you've helped a lot of patients with chronic pain throughout Beaumont's system, and you've really been instrumental in helping Beaumont sort of figure out its own way around this opioid epidemic and sort of learn how to tackle those issues from a system standpoint. So thank you for that. Let's get right into the conversation. We're going to talk about the opioid epidemic. First, a few numbers for perspective. According to the Department of Health and Human Services data, and this is data from 2016, 2.1 million people have an opioid use disorder. 11.5 million people have misused opioids. That's 1 year's worth of data in total. About 42,000 people, roughly 116 people per day, die from opioid overdoses. The economic cost of this is estimated to be somewhere around $500 billion. So I guess the question for starters, and it's a big question, is how did we get here?
Well, one of the critical issues is that if you want to go back prior to the 1980s, there was a general consensus that we were under-treating pain, both acute pain, pain from injuries, pain after surgery, or chronic pain. And pain, especially chronic pain, has probably been our most prevalent medical problem, for the last 100 years. It's been a significant issue. With some recognition that we needed to better address pain, right around in the 1980s, there were some unsupported claims by a group of physicians that opioids were the answer and that they had no safety risk associated with them. And that really was the evidence that began to support the increased utilization. Large pharmaceutical companies grabbed onto that, marketed to physicians and to pharmacies and health systems, and that began to increase the growth. And right around the same time, originally by the American Pain Society and then the Joint Commission, they established that pain should be the fifth vital sign and that it should be measured in all patients and treated effectively.
This is something I personally remember being an issue, and I believe, if I'm not mistaken, that was a Joint Commission standard that was brought down, that we were going to now, in addition to everything else, we wanted to control everybody's pain in the best way possible. That was in the 90s, right?
Yes, that was in the 90s. And so one of the problems is the fact that as we began to use more and more opioids as a predominant approach for the management of acute and chronic pain, it became a significant problem. For example, one of the struggles is that hospitals in the 90s and beyond were being measured by how satisfied patients were, how satisfied they were with their pain management. And there's always been a conflict between satisfied patients in pain management and patient safety. So that was a problem. Another problem, too, is that you had this lack of evidence out there to support the effectiveness for the use of opioids, but its growth was going significantly. And part of the problem is that up until a few years ago, most physicians, nurses, physicians' assistants really had a minimal training and education in pain management in medical school or in their courses or in residency or fellowship. So you really had a lot of gaps in education. We also did not have enough resources for non-opioid related treatments, maybe not enough evidence, and that was another significant problem. We also found, especially in terms of outpatient care, that there was increased volume pressures among our primary care physicians, and they were seeing more and more patients with persisting pain problems. That was probably the most prevalent problem. And because they did not have enough time with their patients to really go through some of the complex issues, making pain a difficult issue to treat, it was much easier to write a script when you really did not think it was a risk. And we quickly became aware, especially over the last decade, that the risks associated with this were far greater than we ever thought.
Absolutely. So I want to key in on something that you said just a moment ago, and that is when we talk about pain as the fifth vital sign, am I right in saying that hospitals, physicians, practitioners, they were effectively being marked down or dinged in some way, shape, or form if they weren't adequately controlling pain? So in other words, if they were not prescribing enough opioids, then it would hit them in some sort of quality metric. Is that right?
Exactly. So one, the focus was to, the metric was every patient would be asked about to rate their pain on a 0 to 10 scale, with 10 being the worst pain possible. And our goal was to, as quickly as possible, dial that down. And when patients left the hospital, we would give them enough medication to assure that that was a problem, especially because oftentimes they don't get those satisfaction surveys for weeks after they've been in the hospital. And that was a problem. But also, if we gave them too much medication on discharge, we have now found that on average 40 to 60% of those prescribed pills go unused, and over 75% of those pills go unprotected. They might just be in an open medicine cabinet in somebody's bathroom, increasing the risk for diversion into the community.
So what was the wake-up call? What was the thing that said, okay, we clearly can't continue down this road, and what was the thing that sort of triggered the pendulum to swing in the other direction?
Well, it basically was the increasing prevalence of accidental overdose deaths from opioids. And I think that was the wake-up call, and people began to look at how are these opioids getting out into the community. And we also discovered that some communities in the country had a greater prevalence of problem. So I think what it did is people began to, it was a shock to our system, and we began to realize was not as safe as we thought it was. And then a lot of people began looking at what are some of the complex generators of this problem and better understanding who is at risk for developing a problem and who not. And one of the unfortunate things is that as we've become aware of the risks associated with opioids, those patients who are using opioids appropriately and are not having any complications associated with them have become more anxious that they may lose the appropriate treatment that they deserve, especially if we think in terms of patients with cancer pain or terminal illness or other types of conditions. So that was kind of one of the unintended consequences of the pendulum going too far to the point of now fear in the use of opioids.
It is fair to say now that the pendulum has fully swung in the other direction. And now we live in a world where, I would say rightly so, we're more aware of the consequences of opioids and the dangers associated with opioids. But we've made it much more onerous on the physician and on the patient to get the opioids that they may need to manage their chronic pain. And so now we live in this world where, well, there's a lot more legislation out there as well that sort of is looking at this. So you and I are both aware of some Michigan legislation that's changed prescribing practices for opioids and other controlled substances. Can you briefly summarize a few of those changes and sort of what's going on in the community right now for physicians who want to prescribe opioids to their patients?
Okay. So in January of 2018, the Michigan legislature began its new laws governing the use of opioids. And basically, it's focused a lot on, one, screening all patients before you prescribe them an opioid on a system, it's called the Michigan Automated Prescription System, or MAPS. Mm-hmm. And we now, all prescribers are now required to screen patients to see every medication that has been prescribed to them, just to see that if they may be at risk. Is the patient telling you the medications that they tell you that they have before you prescribe them an opioid, is that accurate? Or have they been getting other medications that they're not telling you about? So you just want to find out basically how honest is the patient in terms of their medication use history.
So MAPS will give me sort of a list of all the pain medication, opioids, controlled substances that a patient has received. Over what period of time are we talking about?
It'll basically tell you over the, really the last 6 months, if not more.
Okay, very good. All right, so we have that procedure is in place, and now physicians, the expectation is if you're going to prescribe controlled substances or opioids to a patient for pain, you have to check a MAPS to see what other controlled substances that patient has been on, right?
Exactly.
Okay. What other things have we installed in the most recent 6 months or so?
So another is the fact that we've now used what's called the Start Talking Consent Form. Mm-hmm. And what that means is that when you write a script for a patient, for an opioid medication, you need to provide them education about some of the risks associated with opioids, risks such as if they've had a history of mental health or substance use problems, that there is some risk of addiction. We talk with them about safe use and safe disposal of that medication. And then we have the patient, or if it's a minor, the parent or guardian at least sign that form indicating that they've received that education. So that requires us to really educate patients and family members about the risks associated with them. The last is that we now are restricting, through the laws restricting the number of pills that can be prescribed to a patient for acute pain. The law states that you can no longer prescribe more than a 7-day supply. And that's really important because prior to that, the supplies could be up to 30 days worth of medication, and if 40 to 60% of those by research were going unused. For many patients, that's a lot of oversupplied medication out in the community. So that's now a new requirement too, which places a greater demand on prescribers because we have to have more resources to follow people up, especially for those that have more complex pain problems and are going to need refills beyond 7 days for an acute condition.
So with the MAPS, with the Start Talking form, with the limits on the amount of opioids that one can be prescribed, Is this good enough? We need screening, clearly. I think you and I would both agree with that. Is this the kind of screening that we need? Is this robust enough? Or do we need more or do we need less? What are your thoughts?
Well, I think this screening is helpful. I think it's helpful in terms of education, in terms of making our prescribers more mindful to make sure that the number of pills they prescribe are absolutely necessary and not providing any more. But I think one of the other areas that's important to screen is to also to better understand patients' expectations for how much of their pain can be managed. In some situations, we're able to completely alleviate pain, but in other situations, people will live with some persisting pain. Understanding a person's expectations is important. I think we also need to screen for psychological well-being because psychological well-being is actually a better predictor of complications with opioids and pain problems than the medical or pain diagnosis itself. So that's another thing that we need to screen and really try to partner with our patients to work towards both physical wellness but also psychological wellness because it really makes for a better outcome, and we find that patients can live a better quality life in the short term or long term if they have pain, if we do screen for those kinds of issues.
How does one screen? I mean, speaking as a physician now, how do I screen a patient to know a little bit more if this person may or may not be one of those at risk for abusing opioids or for potentially getting themselves into problems with opioid addiction?
Well, two simple questions would be if you ask a patient to rate their pain on a 0 to 10 scale of severity, after they've given you that severity rating, then ask them in that same scale, rate how much you can tolerate that pain, with 10 being the highest level of tolerance. And for the patients who are giving you a high rating of tolerance, find out how they're accomplishing that. For the patients that are not, then you're going to get into their private experience of suffering and understand a little bit about where they are struggling, and that offers an opportunity for some of the risk factors. So I think that's critically important.
Very good. So now that we understand a little bit more about the scope of the pain management problem and some of the new legislative changes that have come into the scope in the last year, let's talk about strategies. One of your major focuses is on showing patients the value of developing resilience and coping skills. Can you talk a little bit more about this?
Okay. And one of the big things that we're focusing on currently is both medical management of pain as well as what we call non-pharmacological management. And non-pharmacological is a big umbrella, and it really focuses on helping people use strategies to improve either their emotional or their physical wellness. So, for example, some of the emotional wellness strategies that we work on are things like learning to engage in activities that improve your mood, learning to monitor negative thinking, learning to better manage stress, learning to make sure you have enough social support, doing things helpful for other people, making sure that you have a sense of meaning and purpose in your daily life, learning not to be so afraid of physical activities, learning, especially if you have chronic pain, that even though something might hurt, it's not necessarily harming you. And this is very important because we know that stress can increase inflammation of the pain sensory system. And so really working on emotionally focused strategies are very important. But also another area of non-pharmacological care is really what we call more functional or behavioral coping, which would mean, for example, working with a physical or occupational therapist. It might be doing yoga or Tai Chi, receiving massage. It could be participating in an acupuncture treatment. And all of these things are really focused upon learning to reclaim your body and some body wellness, and that might include vitality, flexibility, strength, and those are very important in terms of helping people frame their ability to live with pain in terms of strengthening their kind of body confidence.
What I'm hearing then is that this really needs to be a holistic approach, right? So So if I'm a patient who has chronic pain, like the example of the woman that I gave in the beginning, the answer to her issues may have been in part the physical therapy that her physician prescribed her would have been appropriate. The anti-inflammatory medications would have been appropriate. Even the opioids may have been completely appropriate, but you need to go that extra step and focus really on the mind and making sure that you're really sort of approaching this from a behavioral perspective. You mentioned stress. You mentioned managing stress. I recently did a podcast and had a conversation with Dr. Ruth Lerman. We talked about mindfulness and how mindfulness is one way that you can combat stress, and it's been very useful for controlling patients with chronic pain. So what I'm hearing is that's an opportunity. Also, other non-pharmacological things, you mentioned acupuncture. So really the prescription for chronic pain is more than just the pain medications. There has to also be a prescription for some of these behavioral aspects. As a physician, as a prescriber, how do I get access to those things? What do I say to my patient?
Well, it is a challenge because we historically have a gap in non-pharmacological resources and non-pharmacological providers for pain management in our health system here at Beaumont Health and other health systems. But I think the first thing is if you have a motivated patient, to educate them about the importance of emotional wellness and fit and body confidence and activity to make your treatment more important. And if they're a motivated patient, usually you can kind of direct them to community resources. We have, for example, an integrative medicine program here at Beaumont Health. We have pain psychologists where they can take advantage of those opportunities. But some patients are more passive. They're not as motivated. They feel demoralized. They feel kind of what we call like battle fatigue from dealing with the pain.
Sure.
And they kind of over-rely on their physician to provide them with a cure or relief. And oftentimes it's very difficult for them to think about a strategy for their own self-management. So I think kind of guiding those people, and sometimes it may take several visits to try to guide them towards a greater acceptance that pain management really is a partnership between the patient and the physician or prescriber, and they both have a part in making that a successful outcome.
It's a real challenge. Again, I'm going to put on my internal medicine hat for just a moment and think back to the days when I was working in an internal medicine clinic, and you would have 15 minutes or 20 minutes to see a patient who has hypertension and high cholesterol and diabetes, and you're managing all these things in real time. And oh, by the way, I also have chronic pain. And doing some of these behavioral focused interventions, while I recognize the value in that, it's hard. It's hard and it's time consuming to sit and to really have this conversation. But what I'm hearing is we have to do a better job at this. Are we getting better at this since some of these law changes and since we've recognized the opioid epidemic more? Are we getting better at this?
I think we're getting better at the level of our physicians and their workforce are becoming much more aware and mindful of the mind-body connection, and much more aware that pharmacological, surgical treatments are insufficient. So they're becoming much more aware of that. But I think part of the problem is the difficulty in access to the complementary or non-pharmacological strategies. For some patients, they're too expensive.
Mm-hmm. And a lot of this is probably not covered by a healthcare plan.
Some is not. I think one of the big things that we are working towards, not only at Beaumont Health but other systems, is to integrate behavioral health providers and other providers of non-pharmacological care into the ambulatory offices. Because especially for the patient who's worn out, demoralized, if they have to go to 4 different offices to get 4 different components of a holistic treatment plan, they're going to be less successful than if they can get everything in one place that's well coordinated. And so I think that's one of our big challenges, is that the more complex the case, the more the research has shown it has to occur in one place, the treatment.
Let's talk a little bit more about some of the opioid sparing opportunities out there. So I had a conversation with a sports medicine doc who does shoulder surgery, and he was telling me that there's new techniques out there that use more long-acting regional blocks for like a shoulder surgery, for example, where you'd be injected with a numbing medication, and in that critical period of time, 1 or 2 days post-op, you're not reaching for that bottle of pills for pain management because the block is really doing the lion's share of the work. Talk about things like that, and are we doing a better job of picking up on some of these more opioid-sparing things that are out there to help us curb the opioid use?
Yes, especially in our hospitals and our surgical centers, we're looking at a wide variety of, as you were saying, anesthesia blocks or non-opioid medications that can provide some comfort and pain relief to the patient without exposing them to opioids. In some situations, opioids are absolutely necessary. But one of the things we know is that a small percentage of the population, when exposed to opioids for the first time, that may be sufficient for them to develop a problem. Now, that's a minority of the patients. The majority of patients exposed to the opioids for the first time are not going to develop a problem. But again, we still need to really be screening, and the more that we can reduce exposure, the better. But one of the things we also need to do is begin to better screen patients before surgery to see who might be at risk so that we can catch it earlier on. And that is very important too.
And with that, the screening that you talk about earlier, you mentioned earlier, the 2 simple questions, is that the kind of screening are we talking about, or are we talking about something that's a little bit more robust, particularly for the surgical patient?
Right. Well, we would screen for anxiety. Has the patient had a prior surgery that was complicated and they're now having some apprehension? An anticipatory worry about this new surgery? Is there any history of untreated depression, especially recently? Also, has the patient had any trauma? So, for example, patients who have an active PTSD condition, those kinds of conditions may be an issue. Also, is there a history of substance use disorders that has gone untreated? These are all potential risk factors, and if we can identify these things early, we can do what we call pre-optimization, meaning that we can work with that patient to try to get them psychologically and medically ready prior to the surgery, which I think is probably as important as sparing opioids.
I'm a big fan of this idea of pre-optimization. I think this is something that's really catching on. The idea being that you're prehabilitating a patient before they have their surgery, putting a little bit of expectation in the hands of the patient and saying, you're going to have major surgery. You need to make sure you're ready for this major surgery. Physically, you're seeing a lot more hospitals that are latching onto programs like ERAS, or early recovery from anesthesia after surgery, where they're really saying, look, you're going to have some pain, you're going to have some discomfort from this surgery, but we're going to do everything we can to make you physically and emotionally ready before you go under the knife. And I think that that's a great thing. Let's talk, I want to dip my feet a little bit into some slightly controversial waters. I don't think you can really talk about the opioid crisis without talking about something that is very popular right now in the lexicon of pop culture, and that is medical marijuana. So does medical marijuana have a role in managing pain in the face of the opioid epidemic?
Well, there has been, in the research area, some preliminary support for the use of medical marijuana in certain situations as it relates to pain. But one of the biggest problems is the restriction on good clinical research because it's still a Schedule I drug. Cannabis or marijuana is a Schedule I drug controlled and monitored by the DEA, and it is a federal law that has completely restricted the availability of research funds. In fact, the current director of the Health and Human Services really does not envision medical marijuana as ever as an FDA-approved treatment option. And because of the restrictions, we're not really able to approach it. And what it does do is leave a lot of physicians and prescribers of opioid medication at a disadvantage. For example, in our pain clinics, patients, if they have medical marijuana, it's really an either-or. They can have medical marijuana, or they can stop that, wean off of it, and then we will trial them on opioids, but they cannot do both. So there's really not an opportunity to research whether a medical marijuana with pain management might reduce the need for opioids. We might be able to reduce some of the opioid-related risks. So that is a real disadvantage.
Yeah, it is. So we've painted ourselves into a corner. On the one hand, we need more federal support for research, but we're never going to get federal support for research if it's a federally illegal controlled substance, right?
Right, and currently in November, legalizing marijuana will be on the ballot here in Michigan. But even if it becomes legal here, it'll be the same dilemma for the other 29 states. That as long as it's a federal crime, and if the current Attorney General wants to prosecute medical marijuana, it's still going to create a lot of anxiety, and so therefore we're not going to develop the kind of nuanced treatment plans for pain management that might include a little bit of opioids and a little bit of marijuana.
I am seeing some research start to kind of trickle through, and I guess that's not federally supported research, obviously, but what I'm getting the sense is that there are some institutions out there that are looking at this more seriously. Are these foreign institutions, European institutions, or just smaller institutions that are sort of self-funding?
Well, I think there are grants for research, but it's very limited. It's a very limited amount.
Okay.
But yeah, I mean, for example, in the Journal of Pain, which is the Journal for the American Pain Society, there's been several meta-analytic reviews of a wide range of research in the cannabis, medical marijuana area recently. So there is research out there, but it's very limited.
So as a listener, I may be a patient, I may be a family member, I may be a friend, or I may have a friend who I am concerned about, who may be using opioids or who may be using other controlled substances. How do I recognize that as someone who might be listening right now? What are some things that would tip me off that this person needs to get help, and what are some resources that person can get attached to?
Well, I'll give you some. So we would want to look at some of the risk factors that you'd want to look for. One is the individual using opioids, they're not prescribed. So are these opioids they're getting from somebody else? Second, if they are prescribed opioids, are they using more per day than they're prescribed? Let's say they're prescribed to use 2 or 3 a day. They notice they're using 4 a day, or they're using 5 a day. That could be a problem. While they're using opioids, are they drinking a lot of alcohol? Are they taking sleep medication at night and complaining of not sleeping? Or are they sometimes taking an extra opioid at night along with their sleep medication to really help them sleep that night? Are they talking about being anxious and distressed and they can't relax, and as a result of that they're taking medication like Xanax or Klonopin or Ativan, those types of anxiety medications, or Valium or something like that? Are they starting to take that a lot during the day, plus their opioids? That could be a problem. Another thing would be, are they running out of their opioid medication 2, 3, 4 days a week, 2 weeks before their next doctor's visits? These are always an indication that the person has probably got tangled up in the use of these opioids.
What might I do if I recognize this? If I'm seeing a friend who's going through this right now, where do I go? What do I do?
I think the first thing to do is to try to be honest with what you're noticing without passing judgment of your loved one or friend. I think that's important. That's a hard thing to do, to kind of share that. Sometimes if you and somebody else is aware of it, having both of you share that can make it more real for that individual. There is also a community program called Families Against Narcotics, or FAN, and they are in many of the communities in Michigan. And you could reach out to them, and they can provide some guidance. They sometimes have what they call angels people who either have been in recovery or have been affected by others with opioid use problems may be able to provide some assistance. So that would be another resource to think of. There are some police departments that are affiliated with a program called Hope Not Handcuffs. And if an individual in the community believes that they have a substance use problem, for example, an opioid use problem, you can go to that police department, and what they will do is they will call Families Against Narcotics, and they will come there and they will help link you to a community treatment agency, and there will be no problem with the police whatsoever. So that is another opportunity. And usually, if you reach out to Families Against Narcotics, if they can't help you and you have a problem, they can let you know which police departments have that type of program as well.
Well, those are some great resources. Well, Bruce, this is a really good conversation, and I really appreciate your time. I think that's about all the information that we have time for today. I want to thank Dr. Bruce Hillenberg for coming on the podcast. Thank you, Bruce.
Thank you very much. Good to be here.
Do you want to pass along any resources for some interested folks out there? Where can we find more information about you and your program at Beaumont or pain management in general?
So at our pain webpage, which is www.beaumont.org/pain, you can find a wide range of guidelines, especially non-pharmacological lifestyle management strategies and coping approaches for dealing with both acute as well as a chronic persisting pain problem.
Thank you for that, Bruce. And before we leave, I want to remind you to share any questions you might have with us at our email address, which is podcast@beaumont.org. One of these days, Dr. Shahjahan and I will answer our mailbag. And with that, I leave you with this healthy thought for the day. Managing acute and chronic pain is complex, and achieving relief demands a comprehensive, holistic approach. Pain medications may provide some value, but there is a mountain of evidence suggesting that pain medication, particularly opiates, simply aren't the solution to this complex problem. Understanding the physical, psychological, and emotional components of chronic pain will lead us to new techniques and strategies for pain management beyond the medicine cabinet. It requires resilience on the part of the patient, but the dividends are worth the commitment. Being able to free oneself from the vicious cycle of pain, disability, and depression is the true payoff.
Continue your journey to living a smarter, healthier life. Visit beaumont.org/podcast to access information and resources related to today's podcast.